Hello, good afternoon. My name is Daniel Dacombe, and I'm here on behalf of the Addictions Foundation Manitoba.
And I'm Connie Platt, and I'm here with McDonald Youth Services. Before we begin, we'd like to take a moment to acknowledge that our work takes place on Treaty 1, Treaty 2, and Treaty 5 territories, where people Indigenous to Turtle Island have walked, gathered, and lived since time immemorial, and homeland of the Métis Nation.
So the two of us are here today to talk about stigma, especially stigma related to language. During my time at the Addictions Foundation of Manitoba, I have worked as a counselor in the school-based program and more recently in prevention work across the province.
For me, I have been working for McDonald Youth Services since January as the manager of clinical services. And prior to that, I've spent my career working in mental health and adult and youth systems.
So we're very happy that you've gathered here with us today to talk about language and stigma. And we're going to start off with something that's going to be a little bit more participatory for people here in the room. We're actually going to start off by asking you a question. And the question that we've got here today is, how have you heard individuals who use drugs described? Could be in person, could be on social media. What are some of the words that you've heard used to describe them?
Junkie.
So one of the words said in the room was junkie. Okay, we're writing that down. What else?
Messed up.
Messed up. Okay. What else?
Addict.
An addict. Okay. Very common descriptive word. Yeah.
Druggie.
A druggie. What other kinds of things do we hear about them on social media or in person? Criminal, right. And maybe that's an easy one for people to turn to because so much substance use is still criminalized in our society. So when we hear words like these, when we use words like these, it results in a number of negative impacts on ourselves, on the environment around us, and on the individuals who are doing their best to enter recovery. It comes down to a question of worthiness. And I have several social media accounts and I monitor them regularly. And one of the things that I saw going around recently was this photo that somebody shared. And it's a billboard, and the billboard says, "Why is Narcan free to a dope addict, but my insulin is $750 a month?" The implication being, obviously, from this comparison, that one of these people is worthy of life-saving medication and the other person isn't. And what makes that person unworthy is the fact that they are, by the words used here, a dope addict. For those of you who don't know, Narcan is a rescue medication used for people who are overdosing on opiates, and has saved countless lives across the country for several years now. This comes down to a question of worthiness. It comes down to a question of how we judge people, how we decide that one person is worth more than another, worth care, worth support, and worth being supported as they go into and through recovery. And it impacts us in a number of different ways, and all these ways have to do with stigma.
So if you look, I collected a whole bunch of different definitions for the term stigma. Excuse me. And what I found quite interesting is how language kind of almost defines blame also about the circumstance. So if you read from Google, just basic, what is stigma? We've got a mark of disgrace associated with a particular circumstance, quality, or person. So it means that if you have whatever this disgraced circumstance or quality is, then you, for some reason, are no longer a full human or a full person in our society. They talk about an attribute or a quality which significantly discredits an individual in the eyes of the others. So again, here we're talking about people are being labeled or blamed based on an attribute. So one characteristic of their life. As we go on, you can see that actually the last two are the ones that I think probably more clearly describe what stigma is that it's actually stereotypes or negative views attributed to another person because they belong to a certain group or category. So stigma really talks about, it's actually the negative views and the stereotypes that we as individuals and as society perpetuate to keep these individuals kind of in their place, right? We use this language and we use these terms to keep people at a distance. And what's the result? Well, there's a lot of research and literature that shows that stigma has a very negative impact on service users. So they can encounter distrust. So that means that maybe the service providers are distrusting of what they're saying, or maybe they distrust service providers because they've had multiple occasions where they've been let down, or they have been stigmatized, or not being able to access the resources they need. It marginalizes them, it dehumanizes them, it can discourage help seeking, and the World Health Organization states that it's actually a barrier to wellness. So to be able to be well in society, it has to be free of stigma. Influences the access to care that they get, and it also amplifies self-stigma, and we're going to talk about self-stigma in a moment. The impact on service providers, if they're utilizing these stigmatizing language, is that they themselves become desensitized to what it is that they're saying. They can often start to see the individuals that they're serving as less than. It also sets up power and control structures where we're the experts and they're the people who aren't able to get things right. So it sets up power and control struggles. It actually can also lead to subjective perception based on perceived cause and controllability. So cause and controllability when it comes to illness can really indicate what the level of stigma is going to be faced by that individual. So if you think about someone with cancer, someone said, you know what, my great aunt, I just found out, has cancer. And I bet you no one's going to ask me how many hours she spent in the sun or how many cigarettes she smoked as a teen. Chances are they're not going to. But if I stated that I had an aunt who was struggling with addictions, chances are people are going to be asking me, well, when did they start? Why didn't they stop? Why didn't they access supports? So it's very different on how we view it and how we speak of it. Often, service providers can also feel disappointment and frustration because if you have this setup that, you know, you're in power and control and you've got someone, you've told them what to do and they haven't done it, then you can start to feel some frustration or even anger towards the people you're serving. And that obviously impacts that therapeutic relationship. And then there's the amplification of self-stigma for service providers as well, and we'll talk about that in a second. So if you think about all of these stigmatizing results, or the results of stigma, it's really a brick wall, is that every time someone's feeling dehumanized and every time someone feels judged, every time there's distrust in a helping relationship, every time someone feels marginalized or that they have a reduction in access and self-stigma, it really impacts that individual's ability to be able to seek the type of services they need. All right, so we'll move on to self-stigma. And self-stigma is defined as private, sometimes subtle, and it refers to negative thoughts and feelings that develop as a result of identifying yourself with a stigmatized group. And the impacts on service users really move to internalized shame about their circumstance and who they are, a sense of helplessness and hopelessness. Often isolation comes along with that, and that feeling of worthlessness. The impact on service providers is that often they will tend to label service users around negative or uncooperative, not using language that is supportive or hopeful. It can be discouraging, and it also for a service provider is that, let's say we know that 1 in 10 individuals in Canada will have a substance use disorder in their lifetime. We know that 1 in 4 will have a mental health issue in their lifetime. If you are working in an area where stigmatizing language is being used, how would you feel as a service provider seeking service yourself? Often those service providers can become quite isolated again, not seeking help, and can be unwell in the workplace because there's barriers internally. They don't want their colleagues maybe to know that they're part of the them instead of the us. Another thing around here, if you think about self-stigma, think if you're in a room, and I've heard this many times, where someone says, you know, oh, I'm a little OCD today. I got up my office all cleaned up. Isn't that great? Now, if someone in that room has OCD, how do you think they feel about that comment? Most people I know who live with that disorder struggle every minute of every day, and it's a challenge, and they work hard to keep themselves well. So for someone to use it kind of in a flippant stance really disregards the fact that this is a serious illness and can cause havoc in someone's life. So making sure that we're not using those kinds of words, and we're not letting people think that we believe that they're less than because of their illness or because of their disorder. So if we had a brick wall from stigma, this is probably the best picture I could find that would just kind of show self-stigma, where really it's internal, it's coming down towards, often it's quite deep, and that's where people can find themselves in isolation. Self-stigma can make people not want to speak out because they don't want to actually proclaim that they have a need that others see as unworthy. That's good.
Okay. So if we'd like to understand the roots of stigma and self-stigma, we need to take a look at how society has viewed addiction, addictive behaviors, substance use, misuse, and abuse over a long period of time. And while we've come a long way in society in a number of different areas, and at our launch yesterday, we heard about how there's a lot more openness and acceptance in talking about mental health issues and depression and anxiety. There's still some barriers in the way for individuals who are struggling with substance use issues. And these barriers are often placed there by holdovers or remnants of older models of understanding addiction, substance use, misuse, and abuse. Early models of understanding addiction revolved around one of two features. It was based on an idea that substance use, and especially substance abuse, was morally wrong, and also it was a sign of personal weakness. So we didn't look at people who were using as though they had had a struggle. We looked at it as though they were actually making bad choices, and that they were doing so because of a sense of personal sin. A lot of these beliefs were rooted in religion. Some of the most famously repeated statements around them actually came from Protestant ministers, and we hear a lot of those repeated in the two models that a lot of our old school understandings of addiction come from. The first is the moral model. This is one of the oldest views on substance use, abuse, and misuse. This is where alcohol and drug use is seen as a sign of personal weakness or sin. The response to this, the appropriate response according to this model, is to respond with judgment, to respond with moral suasion or persuasion, and to shun those individuals who choose not to change, because it does come down to believing that these individuals are making just bad choices. And you see this reflected in the language these days on social media and in the media, people talking about those who use substances and saying they should just stop. Why don't they just stop? Why aren't they accessing services? And words like junkie, words like druggie, words like dopehead, they all revolve around this idea that substance use is some kind of moral failing. And it's not just the general public that thinks this way. Sometimes service providers start falling into those patterns as well. And this can be, like Connie said, related to frustration, related to burnout. And these are some of the words that I look for, when I'm wondering if a colleague is starting to experience burnout. Related to the moral model is something called the temperance model. And this is one that's not as well understood by the general public, mostly because there's so much overlap. The difference with the temperance model is that the substance itself is evil. So alcohol is evil, and drugs are evil. And this has its roots in not only Protestantism, but in the views taken by a lot of people in North America, especially the United States, many years ago, that the people who exhibited substance use issues were often very upstanding moral people until they started drinking. Therefore, their conclusion was the alcohol was the evil substance causing these people to behave poorly, and the response is to control access to that substance. This is where prohibition came from and why we have all those great movies about Al Capone. This is another response based on sort of moralistic understandings of substance use and focused on the behavior itself. So as a result of these two models that still have some holdovers in our society, we have some of those stigmatizing beliefs and thoughts and attitudes and values that remain in sometimes our treatment facilities, sometimes in our politics, sometimes in our religious organizations, and sometimes just in the general sort of pop culture, public mindset. These get repeated on television, they get repeated in social media, they get repeated everywhere. And when you hear something often enough, you often tend to believe it's true. At AFM and many other organizations like AFM, we adopt an approach called the biopsychosocial spiritual model, which is a mouthful, I know. But this is a model that we're very well acquainted with and one that we've been using for some time now. It is inclusive. It includes 4 different aspects of a person's life, and I'll explain them all very briefly here. The first is the biological aspect of a person's life. This could be genetics, and we know according to some research there may be some genetic susceptibility for certain individuals for substance use issues. It also can refer to the biological impacts of a drug on a person's body and brain, including things like withdrawal and tolerance. Psychological would be the individual's personality, their likes and dislikes, their risk-seeking behaviors, and so on. And as a result of their individual psychological makeup, they may make certain choices that others might not make. We also know that mental health issues are often triggering factors for substance use issues, and the other way around. Sociological refers to your environment. It refers to the people around you. It refers to your family, to your upbringing, to sometimes abuse or neglect, to sometimes social pressures, peer pressures, and anything that's got to do with your environment that influences the decisions you make around substance use. And then spiritual can be a number of different things. We know that if somebody has a strong sense of meaning about their place in the world, a strong sense of how they fit into the world and how they can interact it, and that they're worthwhile. We know that spirituality itself can be a protective factor for people who are at risk for using substances. And we also see that spirituality and spiritual care can be a part of recovery. And there's been a little bit of research to indicate that engaging in spiritual practices can actually cause you to have a little bit more success in that area. So this is the model that we use. We like it for a few different reasons. The first is that it's inclusive. It includes the whole person. It doesn't just isolate them as a body that just needs to be treated. It doesn't isolate them as a person with mental health issues. It doesn't just isolate them as someone who came from I'm doing air quotes here for those on the webinar, an alcoholic family. And it doesn't just isolate it as an issue related to spirituality. It allows for a strong recognition of the individual's experiences because everybody's different. I was seeing clients at AFM for 9 years. I never saw 2 alike. We also know that this model allows for treatments to be adaptive to accommodate every individual's circumstances. So certain people may not have any family history of substance use issues, but their issues may come from a different place, and so we can adapt our resources to suit them. We also know that it's a unique combination of factors that results in substance misuse and abuse. There is no single defining description of an individual who struggles with substance use issues. There's a wide variety of different people out there in the world who have these issues, and we know that by approaching them in ways that are non-judgmental, culturally safe, and client-centered, we actually have significantly higher success rates in treating them. So those are just some of the reasons why AFM, like many other agencies these days at the forefront of addictions intervention and prevention, has adopted this model. It helps to reduce stigma, it helps to reduce stigmatizing language, and helps to break down some of those barriers that might be put up in place if an individual shows up and believes they're going to be judged and believes they're going to be neglected, or that they're going to have to, before they can get any kind of treatment or any kind of support in their recovery, that they're going to have to make some kind of repentance. That's not necessary. With this model, we actually look at the whole person and are able to deal with their unique circumstances.
So how can language make a difference? Many people in the room will know that I have recently become a nana, and 2 years ago, and I got to watch this little one start her communication journey. Little sounds initially, up until the point that 2 months ago I got a hug that included a "I love you, Nana," and it just about, my heart was going to explode until she added "sometimes" at the end. So you love them talking, but so anyway, I feel she was clearly letting me know how she felt, and I think that language is that important, right? It can make your heart swell, or it can make it hurt, and being mindful of what we say and how we say it can really make an impact for the people that we work with and the people we work for. There are a lot of wonderful different types of theories and practices and lens to look at language through. And the three that I'm going to kind of discuss today are the three that I see most helpful and use most often in mental health and addictions. And really because they are people-first language users. That's what these are for. They're supposed to help you to make sure that the individual that you're serving is kept at the forefront. It is their service needs and it's their goals that we're here to work for. The other thing is that language actually speaks to our assumptions. So when we're using this language, we're trying to get rid of the assumptions. If you aren't sure about what someone's experience is, just asking them to explain it to you can be really powerful to help them move forward in their journey. So we'll start with recovery-oriented language, and recovery was actually started around the same times as the civil rights movement in the United States, around 1960s and 70s, and as well with self-help groups like AA, where recovery was a main tenet of the program. Recovery does not equate with cure. It actually refers to living a satisfying, hopeful, and contributing life, even when there are ongoing limitations caused by mental health problems, addictions, or illnesses. So it's not about getting rid of whatever it is that's going on for you, but it's more about being able to live a life that you feel is fulfilling and purposeful, and that you're a contributing member of our society. Recovery-oriented practice has 6 dimensions, and it really looks at creating a culture and language of hope. So we'll talk a little bit later about that, but making sure that we're always instilling hope. We know when it comes to suicide, hopelessness is actually one of the most, or one of the strong indicators of someone who is not doing well and is at higher risk of death by suicide. So hope is a really important piece to our work that we do. We also want to make sure that we understand, like Jeremy shared, that recovery is personal. Every single person who walks through our doors has a very different experience and a different history. They also have different goals and wants in their life, so making sure that we're keeping that in mind as well. And then making sure that as much as possible, all individuals can have their families, and that can be defined by them, be a big part of their planning and their treatment and their support systems. Again, not looking at them for one piece of who they are, but who they are as a whole. So if we want to go through these on the Mondo pad, so here's an idea of how our language could be used just slightly different, and it can make a real impact on what the meaning is behind it. So Mike is non-compliant or refusing to take medications. So instead, we could be saying Mike is choosing alternatives to medications, right? So we're not putting blame, and we're not stating that he's fighting a power, right? Because non-compliant is a power and control word. So we're making sure that we're open to the fact that Mike has choices, and if he chooses not to use medication, that's okay. There could be a million reasons why he doesn't want to. So Susie is an addict, and again, we talked about that, making sure Susie's experiencing or is diagnosed with a substance use disorder. Mike is decompensating. Mike's experiencing an increase in symptoms. Susie is manipulative. Susie is trying hard to get her needs met. And Mike is refusing support, and Mike seems unsure of the next steps. So these are ways, again, if you think of that first column, those don't leave you feeling very good about that person, right? It kind of is, it's quite negative. Whereas the other one is saying it's very hopeful. They're trying. They're making the best choice they can today. So recovery-oriented language really gives you that hope and that place to build from that's not punitive or negative. Next is strength-based. And here we're just really focusing on the innate strengths of individuals, using personal strengths to aid in recovery and empowerment. And these ones, so I'll go through them, some of them as well. So Henry committed, completed, or was successful at suicide. So the correct terms are actually Henry died by suicide, Henry ended his life, Henry took his own life. You can use any of those terms, but when you say Henry committed suicide, it actually goes back to olden days as well, where suicide was actually a crime. And crimes are committed. That's the term that we use to let you know that it's related to the justice system. So by saying that, we're actually saying he committed a crime, but he didn't. That's not on the books anymore. Betty is homeless or has housing problems. Betty is experiencing challenges in securing safe housing. Right? So Betty's trying. She's trying hard. And homelessness isn't something that you are, it's something that you experience. Henry fell off the wagon. Henry's experiencing a recurrence. So anyone who knows anything about recovery knows that that path tends to be a winding road. And we need to actually plan for recurrences to occur because they're going to, for most people. And we need to be ready to support, and we need to normalize that so that they're ready to ask us for help in those times. Betty overdosed last night. Betty suffered an overdose last night. Because you wouldn't say Betty heart attacked last night, right? We wouldn't say that. Henry is violent, or instead we could say Henry broke a window once when he felt overwhelmed. I find when it comes to aggression and violence, it's always best to actually put down a behavioral statement of what actually occurred and the context in which it occurred, because otherwise it kind of paints a really negative picture. And is Henry violent every minute of every day? Or did he have one episode where he's really overwhelmed and didn't know what to do? So those are very different meanings behind them. And our last one is the trauma-informed language. Trauma affects a person's capacity to actually be self-compassionate as well. So often self-stigma can be quite high for individuals who've also experienced trauma. Our words can affirm that self-stigma, or we can actually challenge maybe some of it with person-first language. So the 5 principles of trauma-informed care are safety, emotional and physical safety, voice and choice, so that they need to know their rights and they need to know that their voice can be heard and that they are the ones who are leading their plan and their goals. Collaboration, which means we have to share power, which isn't something systems are great at doing, but we do have to do it. To be trustworthy, so that when we say that we're going to do something, we do it, so that we're not putting them in a position where they can't trust us. And then empowerment, we need to prioritize empowerment and skill building so that these individuals are able to feel that they're competent and confident in being able to take on the challenges that they have. And really, overall, what we're trying to do is avoid re-traumatization through the helping process. And language is huge for that. So if you think about it, if the first time I went as a trauma survivor to a therapist and I sat down and the first thing was, what is wrong with you? Right? And as much as we kind of laugh, that's actually how most people hear it on the other side. So if we say, what happened to you? Share with me your experiences. That's a very different approach. They just want attention. I see that written sometimes in reports. And really, they're just working hard to let their needs to be known. And we're not going to get anywhere if you aren't willing to participate, which is actually quite an aggressive statement. And what can we do to make this a safe space for you instead? And what about the you have to sign here? You have to sign here, and you throw a form or something across the table. What about let's review this form together, and you can ask any questions that come up for you. And then why didn't you access any of the resources offered? Right? I met with you last week. I gave you a bunch of resources. Why didn't you do something with those? So instead we can ask, what challenges did you encounter when accessing resources? Because now we get to work with them to help problem solve on what challenges and barriers are in place that are making it hard for them. So changing our language can really make an impact. And one of the things we're going to be asking of you today, I'm making an assumption, I guess, that you're here because you want to learn about how to change your language. And so we're going to give you some ideas on how to do that. Because it really does start with us, right? It starts with every individual. And it'll take longer for some of the more systemic stigma to move away. There are policies, procedures, structures that hold those things in place, but we're starting to see them change. And if we have the ability to start to influence the circles that we're in and to influence how we're communicating with the individuals that are seeking our service, then we can start to make an impact. So it starts with me. The very first thing I wanted to talk about was repair. Because one of the worst things I find is when someone gives me a list of things to do that I find out that I haven't done and that I've probably done all of it wrong. And how do I ever go back and face that individual now that I know that I've been saying it not in the right way? And I don't want anyone to feel that shame. Because you know what, we all make mistakes. And moving forward on your language journey, you're going to make mistakes just like everyone else. So how do we repair? And repair is when you take a moment, an opportunity to actually sit with the individual and you actually try to repair some of the damage that might have been caused by some of the language that you've used in the past. So be genuine, right? This isn't like, oh, I better click this off my, okay, I apologize, that one's good, we're done. You can't do that. You have to actually go in quite genuine. Approach with curiosity, which means that we're not making assumptions. If you wonder something, ask. Ask them for feedback about your work and your language. And if they've noticed a difference maybe, or if they have noticed some things that activated them before or made them feel not great, so that you can be aware and you can be mindful not to use those words again. And then apologize. Apologize when appropriate. If you did say or do something that was not supportive of their recovery, apologize. I'm really sorry. I just have learned at a wonderful lunch and learn all about language, and I want to apologize because I think I might have said something before that might have hurt you. Right. And then being a language champion. So how do we respectfully challenge others? Because we can change our language, but we can't necessarily control other people, but we can influence them. So John used again, says Jeremy, he's really out of control. We're in the lunchroom. And I'm like, oh, I'm concerned for John too. I think I might reach out to him today. Or it looks like Tamara forgot to take her meds today. She's dancing in the lunchroom. Well, that doesn't sound like Tamara. I wonder if she's feeling okay. I'll reach out to her. So those two are both really great examples of reframe. So we're just taking what the individual said and we're kind of moving way over here with it and saying, oh yeah, me too. I was worried about him too. Because maybe their language didn't say that, but maybe we can actually give them an out, right? We can give them that out. And then that reach out at the end of each one. I think that's really important, that when we're modeling language for someone else, that we're saying, and I'll reach out, and I'll connect. So we're going to let them know that we're not going to just stand around and gossip about them. We're actually going to do something. The next one, why do my tax dollars have to pay for some homeless guy? And then I would say, I actually cannot imagine what it would be like not to have a home. And so that's where we're using empathy to try to change the direction of that conversation. I'm also normalizing it that this could happen to me. You know, this individual's not just a them, they're an us. We need more security if we're going to serve addicts. And this is where you can, I thought was smart, was to go in with, well, did you know it's a fact that people with mental health and addictions often, or tend to be more likely to be victims of violence than perpetrators. So educate, right? Educate. If you hear someone say something, educate them. And hopefully you'll start to see a change with the people around you. And then for yourself, to commit to changing language, really making sure that it's free of jargon, right? Because you know what that does? That puts us in that power and control again. I've got all the big words. I've got all the answers. Am I sincere in what I'm saying? What else might I be saying with the words that I'm using? Is what I'm saying consistent with my body language? Because 7% of communication is verbal and leaving 93% nonverbal, and 55% of that is body language and 38% is tone. So what else am I saying? Someone with a trauma history is going to pick up really closely if your words and your body language don't match, because they're looking for safety. So make sure that they're congruent. How might my words be read or received? Is what I'm saying relevant and realistic in this situation? So I've seen people before say, you know what, do some self-care, take a bubble bath, or you should go and get a massage. And this person is experiencing homelessness and doesn't have access to financial means. So was that helpful? And then the last one is, am I conveying hope? So when I'm talking to the individual, am I talking about their future plans and their hopes and dreams, or are we always talking about their past and about the decisions that they've made that have gotten them here, or are we talking about all of the horrible experiences they've had, right? Try to inspire hope that things get better, things can get better.
You know, Connie, I think that one of the pieces that I've talked about the most with some of my clients and their families has been how our words are read and received. So often one of the things that people who are using substances will hear from their loved ones is, we want you to stop using. We want you to stop using, right? That's the message. But so many of these people are using to cope, are using to deal with the effects of trauma or mental health issues. And when we say to them, we want you to stop using, what they hear might be, we want you to stop feeling better. Mm-hmm. And that could be a very frightening thing to hear from a family member, a loved one, or even from a helper like all of us. So we've heard a bit about what language and stigma can do. And at the beginning, we talked about the words we've heard about individuals who use drugs. I'm very curious what all of you would say. How would you describe individuals who use drugs? What are some of the things you would say about them and to them?
How they're coping.
Coping, yeah, they're coping. This is how they're coping. What else?
I find that asking what's happening, what's going on.
Asking them what's going on,
Yeah.
asking them what's happening.
It's not the direct. I know that is there some reason behind?
Mm-hmm.
Drug is not drug, it's coming from somewhere else.
Right, you're looking for the reason behind it, yeah.
What's happening, how do you feel?
Yeah.
What's maybe bothering you?
Mm-hmm. So looking for the reason behind it, asking how they're feeling, yeah. What else, how else could we describe or respond?
I've seen, a lot of like resiliency and a lot of like really great problem solving.
Resiliency and really great problem solving.
Yeah.
Yeah.
Just trying to get their needs met. And
yeah, just trying to meet their needs. Yeah. Because it's a coping mechanism so often, and it's one that generally works for quite a while, even though it comes with many other issues. It does fulfill some kind of need, doesn't it? Yeah. So that's a good point. And then there's a hand in the back.
I'm a little bit different in that I'm legal counsel at a woman's place.
Okay.
So when I have somebody, my role is a tiny bit different in that if I'm trying to, I guess, talk to a judge about what's about happening, and I bring in the therapies that she is in and try and convince the judge that way that, yes, there's an issue, you have a drug test that's come back positive, I can't do much about that, but I can say that she's taking steps to resolve.
So the answer for those in the webinar was from someone who's legal counsel and who was saying that you'll often use language that's very affirming of the steps they've taken.
If we can.
Yeah, as much as you can, yeah. Yeah, definitely. I've heard from families and from people who work in the harm reduction field like we do, words like survivor, words like resilient, and I think those are such important words to use when we're acknowledging people and their coping. One of the words that I've tried really hard to get out of everybody's vocabulary when we're talking about drug use is the word dirty, because I hear that a lot. People say like, "Oh, I'm trying to get clean because I've been using," and the response that I've given sometimes is, "Whoever said you were dirty? You're trying to get clean. What's that about?" I think that there's been some really great responses in the room. So we saw that picture from social media. Why is Narcan free for a dope addict? So I have a much better. I have a much better version of that picture. Because sure, there are legitimate needs out there, and I think $750 a month for insulin is very high. But just because needs exist for one group of people doesn't diminish or delegitimize the needs of another group of people. And I'll say this, I'm so thankful that Narcan exists because there's people that I care about who use substances, and I'm glad that they're still alive. I'm sure we could all say that in this room. And the more you interact with people who use substances, the more you generally begin to care about them, and the happier you get that we have things like Narcan. Now, if we want to deal with the insulin issue, that's a whole other bag of cats. But we have to acknowledge that both of those people are worthy, and by reducing the use of words like addict, will actually help the rest of society to see that. Want to end here pointing out that for those who might not be aware, we do have the Manitoba Addictions Helpline, which is available both online and by phone, where you can access a trained counselor and get information about addiction services in the province for yourselves, your clients, your friends, your loved ones, anybody who might need it. And this is just one of the initiatives that AFM operates in partnership with so many other agencies like Mental Health Youth Services. We're very happy that you came to our webinar today. We've saved some time here at the end for questions for the group, both online and in person, and we have our Oompa Loompas helping us out here with the online stuff. So we wanted to open up the floor to some questions. Just so you're aware, because of the microphone, I will need to repeat your question once you've asked it. So if you're confused why I'm doing that, just so people can hear. So does anybody have a question that we could start off with? Go ahead.
So I'm going to trauma-informed language. So I'm attempting to practice trauma-informed law, which is a part of law that is coming out quite successfully, but this isn't something we learn in law school. It's sort of something that we go up. So my first question is AFM reaching out to defense counsel and also family, so I do only family. Are you reaching out to lawyers who work with domestic violence victims and sort of educating on them? Because, I mean, when you talk about let's lower down the legal jargon, it's ingrained in us. So that's one of my questions. And the second is, what are some of the things that you're noticing when clients go to their lawyers and do they come back to you and they're just they're confused about what the heck is going on? So what are some tips that you would have specifically, I guess, for my profession?
Okay, so that was several questions. So I'm going to do my best to summarize that for the webinar attendees. One is you work in as a lawyer, and you're doing your best to practice trauma-informed law, which you mentioned is not something that I guess was discussed that much in law school. So one of the questions was, is AFM reaching out to defense counselors and also to lawyers who work with families involved in domestic violence?
Yeah,
is that correct? And the second question is, what have we noticed in terms of what our clients are saying to us once they've been meeting with their defense counsel about like how it went and what they could do to kind of improve that. So I'm going to answer the second question first because it's the one I've got the sort of more informed answer on. When I was working with clients, and many of them were also involved in the justice system, after meeting with their own lawyer, there would often be some just kind of confusion about the terminology. So sometimes the legalese, as I think the word is, became a bit of a barrier. Not in many cases, the lawyer was very informed and was very supportive and was very good to work with, and they spoke very glowingly of their lawyers often, especially when things went well in court. One of the things I do remember hearing is that occasionally clients would feel like they were annoying their lawyer by having some complex and enduring issues. And I think this is something that we see with service providers in a wide variety of arenas. I recall a study that came out several years ago where doctors were asked, how do you feel about working with people with addictions issues? I think the study even said, how do you feel about working with addicts? So right there we've got some language issues. But and a lot of the responses back were, well, it's very time consuming and they always lie and there's all this, kind of stuff built up around it. And so if you're approaching your clients like that, then how are they going to, like they're going to pick up on that, like Connie said. So well, we have a lot of communications happening non-verbally. So I have heard that from some clients, and definitely not the majority, but that's just one piece that kind of comes to mind. As far as the first piece, how AFM works and interacts with legal counsel, I'm not. This would be something that I would not have a good way of knowing just in the positions that I've held at AFM. I'm kind of making eyes at somebody. Do you have any other thing to add, Denisa?
We're always looking at ways we can collaborate with agencies and with community organizations, and if there's opportunities, I'd love to chat with you. How about see how we can collaborate?
Yeah, the response from one senior AFM staffer was that we're always looking for more opportunities to collaborate, and we're open to definitely hearing more about them. And then I see another hand.
We have a partnership with the Winnipeg Drug Treatment Court.
That's true, yes.
Yes.
So Winnipeg Drug Treatment Court is the obvious answer that I should have thought of. Correct. Thank you, Eva. because I've been there and I've helped out with that program. But it is a program that's been in it now for how many years? Several years, and has seen some really great successes. I also think that not only working with legal counsel for the clients, but also with prosecution and so on. So that'd be one example. It'd be great if that program was like
expand it to Manitoba Bar Association.
So good question. Thank you so much. Does anybody else have a question? I don't see any coming up on the screen behind me, so I'm not sure.
We have a shout out from the Education Center in Flin Flon. All the staff and students are eating lunch together and listening in.
Well, hello, Flin Flon. We're glad you can join us today. How's the weather up there? Did they say how the weather was? I'm kind of curious. So there's a question in the back, I think? Or, oh, sorry, go ahead.
I have multiple questions.
Multiple questions,
I
excellent.
apologize. I guess one of the things is, do you have trauma-informed language that specifically deals with women with addictions issues that are also facing domestic violence? Is that something that AFM is exploring, or does it sort of fit in?
So I'll just repeat the question, and then I'll allow Connie to answer, because I can kind of feel you revving in neutral over here. So the question was, do we have specific trauma-informed language for discussing women who have substance use issues who are also experiencing domestic violence? And so I'll turn over to you, Connie.
Okay. So I can't speak to AFM, but my suggestion, I guess, would be that you connect with Clinic, with a K. In Winnipeg, it is still considered probably at the forefront of trauma-informed care, and so they would probably be best able. And they do run a program specifically for women who have experienced domestic violence. So I think that it would be a good fit. Yeah.
And then final question, the slides that you have put up, they're very informative. I have some questions regarding some of the sources, because if I want to use some of the information in there, I will have to present the source. And somebody above me will be making a decision.
They will be, yeah.
Accept it. So is there, are these being sent out, or?
So the question was, a very good question, do we have references and sources for the slides that are being used? And Connie, you're nodding, so.
I do for my slides.
Okay, so do you have, well, that felt a little hostile, but okay. So, the answer was yes, and we can send those out by request.
I'd just like to add, could I get the slides with their sources?
Mm-hmm.
Yes, we can make the slides available, no problem. And those will be available, I'm not sure exactly when we'll be able to make those available, but with sources, we should try to we'll get that done soon and let you know.
Yeah.
Great. And I had a question for you, actually.
There's a question, there's a cross question happening in the room, so I'll try to narrate as best as I can.
So far, as a general, people who know about the law and justice and legislation, these are very old books, right? The language used in our legislation and law system, it's not actually even any kind of friendly with the people we are serving, right? So is there any initiative around that to make that change at the legislation level, the language we use in our code?
Okay. So I'll summarize that really briefly. The comment was that the language in our criminal code and many other places is fairly archaic, I think would be a good word to use. And in some cases, in most cases, in lots of cases, not trauma-informed and not kind of following all the very clear rules that we laid out here today, I think. So the question was, is there any plan on working on that or changing that or updating it for those of us who don't live in the 18th century? So the question went to the individual with the law degree. So please go ahead.
So I'm going to put a giant caveat on this. I am a young lawyer, and my experience in the legal system here in Manitoba is just in family law. So there's many things going on all over the place, and there is many organizations that are trying to change that. I've obviously talked to mentors, and other colleagues, and that is something that has been recognized, that is a problem, and simplification of language is important. I practice in Ontario. Ontario has simplified quite a bit of their forms to take away Latin, for example, on a form that somebody gets for their petition for divorce. But again, this is personal experience. I cannot at all talk about what the Manitoba Bar Association is doing, what lawyers are advocating for. I will tell you that I have attended events like this for lawyers where we share information, and there has been questions raised about how can we, especially for lawyers like me who work with the more vulnerable sections, that how can we change it so it becomes a little bit more ability to resolve things. And there are changes that are coming. I am hopeful about the changes that are happening to the family law system. And I will not be able to tell you whether or not it is. I am hopeful, is all I can say.
Okay, so the summary, there was a caveat at the beginning that she is a young lawyer. That's still 100% more lawyer than I am, so we're thankful you're here. Who practices family law, and you mentioned that there's many organizations and many individuals and many government factions involved with lots of moving parts, it sounds like, in this particular arena. And you're from Ontario, and Ontario has simplified many things in their legal practices. You're from Manitoba. You were practicing in Ontario, sorry, including removing Latin from a lot of their forms. You said in your personal experience, and you can't speak for the Manitoba Bar, but you are hopeful, which is good to hear, that there have been other meetings with lawyers working to try to talk about how they can bring down some barriers. There are some changes that you're hoping are going to happen, and I think there's an overall general message of hope. So I think that's hopefully answers your question and gives the Coles Notes version for those involved in the webinar. And Flin Flon says they're dealing with light snow and some cloudiness. So you folks stay safe on the road out there. Any last questions before we wrap up? Sorry, go ahead.
I'm just wondering what you're seeing, like in terms of your clients or folks at AFM, like what's kind of the biggest barrier to accessing supports? That are some of the big barriers.
Mm-hmm. So the question is, what are some of the biggest barriers for accessing supports? There's a number of different barriers that people experience. A lot of them have historically been systems navigation, which is why the rapid access to addictions medicine clinics have been such a benefit for those individuals, because it's designed specifically to be low barrier, and so anybody can show up at the RAM clinics, they're called, and we can show up there and access services fairly immediately, and without waiting or calling ahead and having to make appointments, and think about how challenging it must be to make an appointment if you don't have a cell phone, right? How do you call ahead and all that? So for them, being able to show up and having those low barrier options, I think is really important. Other barriers that I think we talked a lot about stigma and self-stigma as being major barriers, and poverty is a barrier for many things. But I think that we have been doing a pretty good job in Manitoba trying to identify what those barriers are and work around them, or create access points that reach through those barriers or past those barriers, or break them down as much as possible. One of them several years ago was the Co-Occurring Disorders Initiative, which was done in conjunction with regional health authorities to train individuals in both the addictions and mental health field and some overlapping skills to make sure that when people entered the system, there was no wrong door for them to go into. And the rapid access to addictions medicine clinics is just one more example of how we're trying to continually improve that. Thank you for the question. Are we out of time now?
I think time for 2 public service announcements.
Okay, so we have Bill coming forward to do some PSAs.
So,
oh no, we're going to do them.
2 more lunch and learns, one on Wednesday and one on Thursday. If you could just, and this is
For participants?
Sure. This
So-
is right.
So I'll read this now. I've been handed something. I feel like a news reporter. This is very good. Or I feel like that Blue Eagle Muppet from the Muppets. So there's There's other Manitoba Substance Use and Addictions Awareness Week Lunch and Learns happening this week. There's a Wednesday, November 27th at Clinic Health Center. That is tomorrow, from 1 p.m. to 2 p.m. Angie Cody, the cultural advisor from AFM, and Kathy Milla, a Reiki practitioner, will be speaking about holistic services, integrating mind and heart-based work. This Lunch and Learn explores the importance of holistic services and support in the journey of recovery and healing. There is a webinar link available on our website, I believe. And if you're planning to attend that Lunch and Learn, please send your name and contact information to the link provided. We also have another Lunch and Learn occurring on Thursday, November 28th, located at Siloam Mission from 12 until 1. Scarlett Solomon, a rehabilitation counselor for AFM from our Riverpoint Center, will be discussing how to explore spiritual health. So this Lunch and Learn explores the importance of spiritual health and recovery and healing, and there will be a spirituality exercise facilitated during the session. So there's going to be some experiential component there as well. And there will also be afterwards a tour of Siloam Mission provided. So those are our webinars coming up this week. And we also want to let you know about our youth video contest this year. We've done these for several years running now, and the results are always wildly entertaining. This is a contest for youth in Manitoba who can make videos to win prizes. And the theme this year is what youth need to know about alcohol. So in a 30 to 90 second video, young people can submit what they believe are important points of information for others to know about alcohol use. The first prize is $500 in gift cards, and the prizes go down slightly from there. We have a hard date of April 20th for the end of the contest, and people can submit videos until then. So pass this on to any youth who you might think would be interested in it.
And the age of 21, Daniel.
Youth is up to the age of 21 for the purposes of this contest. So it's going to be very interesting. We share all the videos from previous years on the internet as well, and they're available on our website, I believe. So we hope that you will pass that on to any young people you think might be interested in. I think that's it for us for today. We want to thank you so much for coming out and listening to us talk about such an important issue. We wish you the best of luck in reducing stigma in your own contexts. Thank you so much.